I'm Jeff Harness. This is Anna Marie Golden. I'm from Cooley Dickinson. She's from Bay State. And I'm going to kick us off with kind of a big picture overview of healthcare and how it's changing, why it's changing, Affordable Care Act, that kind of stuff. And then Anna Marie is going to get a little more specific with some real life examples from Bay State, talking about community benefit, determination of need. And then we're going to allow plenty of time for just questions, answers, discussion. I think we're going to leave that door open just for a minute for stragglers. And if it gets noisy or stays noisy, then we're going to close it. If anybody has any trouble hearing or whatever, just raise your hand and we'll figure it out. So with that, let's get going. So first of all, thinking just a little bit about health equity. And as someone who prepared this a while back, before I heard the speakers this morning, I'm thinking, wow, I hope my bullet points kind of match what was said earlier. And I think they more or less do. So it's really an equal opportunity for everyone to be healthy. So, think of the shoe thing, right? There's an opportunity there to get the right size and the right color of shoes. There's a handout up front if you want one. Sharing the creation of environments that support health. Special efforts to improve the health of people who have experienced social or economic disadvantage. And then the last one, attend to the root causes of health disparities, especially the social determinants of health. I grabbed that somewhere off the internet. I looked at many, and this one just seemed to speak to me. It's pretty concise, and I think captures some of the really key points. So, we think about healthcare and it's changing. I mean, everybody knows that, right? You read the New York Times or any magazine, and you see all these articles. You probably experienced some of it in your own life. But the question is, why is it changing? How is it changing? And as it does change, what's the role of a nonprofit hospital in that? Does that look different now moving forward than it has been looking? We're going to get a little bit into community benefit. Quick show of hands, how many people in the room know what community benefit is? So most of you. So don't worry if you don't, we'll tell you, all right, in a minute. We need to think about how hospitals engage with the community. Looks a lot different. In the old days, you broke your leg, you came in, we treated you, you left. And things are beginning to look a lot different in the relationship that hospitals have with communities, with patients. And then just lastly, we'll touch on what are the community benefit requirements of the Affordable Care Act. So here's a really great slide to show you why healthcare needs to change. We're not going to have enough money to keep going at the rate we're going. That red block up there is Medicare. And we have enough money for now, but at the rate things are going, we're not. Medicare is going to eat the entire federal budget at some point if things don't change. And I don't think anybody really wants that to happen. So something different has to happen. And that something different that has to happen is the payment system. So again, you break your leg, you get cancer, something bad happens to you, we get paid. If nothing bad happens to you, we don't have any money. And so that's been the rub all these years. We built the wrong system in our country. We built it based on profit, greed. There's really no other way to put it. That's simply what we did. And there were really strong interests like hospitals, physicians, who didn't want things to change because it benefited them. But it didn't really benefit you. It didn't benefit people who rely on these institutions for a fair chance. So we have an opportunity now to do something different, and you can see this red blob is going to eat the federal budget. We have to. And so my view of the world and change, at least for healthcare, is that things were moving in a different direction anyway. The marketplace was going to push change. And the Obama administration, the Affordable Care Act, pushes that change even quicker. So I think it's going to be a really interesting 5, 10, 15 years. Stay tuned and come back and we'll see what happens. So the question for somebody like me, who I'm a community health guy, but I work for a hospital. So the question is, do we worry about the 10% of patients who are sick and have chronic illnesses and really need us to be there for them? Or do we worry about the other 90%, everybody else? And so this curve idea, this bell-shaped curve, the idea here is really to shift the curve to the left towards everybody being a little bit healthier. We certainly can't ignore the 10%. They are the folks with chronic obstructive pulmonary disorder, and they can't breathe, and they need medication, and they're in and out of the hospital all the time. But the other 90%, the rest of us, what can we do? What steps can we take to shift that curve? In Vermont, they found that when they could get people to be just a little bit more active and collectively lose an average of 5 pounds, diabetes rates went down. So we're not talking about enormous change that's needed. We're talking about small shifts. Because of the largeness of the population, can have a big impact. But first, we're going to talk just a little bit about that 10%, because that's really where the action is for hospitals and for healthcare. So reimbursement changes drive everything. And the days of fee-for-service are starting to go away. They're not gone yet. We're still getting most of our payment based on that. But we're starting to experiment with new ways of getting paid. Things like a per member per month fee. Things like a global payment. So in other words, just give us the money before anything bad happens to you. Well, now the incentive has shifted to prevention. And once that shift takes place, we start talking about wellness, smoking cessation, health education. But at some point, you run out of, it's diminishing returns on that. And then you've really got to start looking at the wider community. Things like health equity, things like policy, the environment. So you can think of these expanding concentric circles. We're not there yet. We're not at a point where we're not at a point where we're ready to say, here you go, community project, go do something great with the environment to change policy. We're doing some of that, but for the most part, the mindset for a medical system is really around patient-related change. Focus on value, meaning cost and quality, and not volume. So that's an enormous shift for us. All of our systems have been built on volume. We want all the patients to come to us all the time with all the bad things you've got so we can treat you and bill you. And I don't mean in an ethical sense, but in a financial sense. That's how it's set up. So that's beginning to change, and we're talking about that. We still have fewer than 50% of our patients on this new payment system, but we can see the day when it will be over 50%, which will probably be some sort of a tipping point, to use that phrase. We'll be focusing on patient satisfaction way more than we ever have, because people will have more choice than they've ever had. And we're seeing that, and we're all feeling pressured to change, and to really have great customer service, really be attentive to that, and not make the assumption that we can just have kind of mediocre customer service and that will be okay. So if we let you down on that, those of you who live in Hampshire County, be sure and let us know, because we need to hear it. So interestingly enough, we're focusing on decreasing readmissions. And that's been a really interesting conversation internally, because on the one hand, we now get penalties for certain types of readmissions. But on the other hand, we still get paid for them. So does the payment outweigh the penalty? Kind of does. So it's kind of this interesting place in time where it's getting easier to do the right thing, but it's still easier overall to not do the right thing. So just a conversation that I think we're going to be having in healthcare for a while to come. We're seeing patients be way more active in decision making than they've ever been before. We can all just jump on the internet and find out all sorts of information. Not all of it's correct, but we can find it and print reams of paper and go to our doctor and say, I want this, or I don't want this, or whatever. Or usually, I have this, and this, and this. So the doctor-patient relationship is changing really dramatically, and the doctor's bedside manner is becoming more and more important, again, because people have choices that they didn't have before. So, that's something that we're working on. And then lastly, I think improved coordination and communication. You're going to see that just more and more and more. We have to coordinate better. And the system, as I said, has been built on profit, and it's been built on disease-specific sorts of profit. So you might have somebody with congestive heart failure, and they might have a little bit of depression, because when you're not really mobile, you can sometimes start feeling kind of depressed. However, the mental health system, that's over there, and that's a different payment system. It's a whole different world, and those worlds don't intersect. Or dental, that doesn't intersect. Is the mouth part of the body? Are the eyes part of the body? Is the brain? But our payment system doesn't work that way. It compartmentalizes everything. And so it's on us really to figure out how to coordinate and communicate in ways that benefit the patient and the community, but in ways that just the payment system and the whole structure does not make it easy on any of us to do. And so lastly, within that, we need to focus more on culturally appropriate services. You heard my coworker, Betsy Shalley-Jensen, on the panel earlier talk about that. So we have a new initiative, and we're working on that to be just more friendly. We have a new CEO. She started in April. And one of her first, I think it was her first month on the job, it was the Pride Parade, or the Pride March. And she came back kind of excited, let's start an LGBT culturally appropriate initiative. What do you think about that? And what I and what others said to her was, well, we've got news for you. It's not just that we're not culturally appropriate for that group, we're not really culturally appropriate for anybody. So the starting point is really the vision that we want to be that, the mindset. And then of course, then you do roll out some specifics, whether it's Latino or LGBT or whatever. But I think we need to really expand how we view culturally appropriate. And there's a phrase I like called cultural humility, but it's really asking the patient, getting to know them. I mean, I could be in a room and the patient next to me could be another 52-year-old white guy, and it doesn't mean that we think alike. So you really need to ask each patient, each person needs to have an opportunity to define for themselves what kind of care they want. So this transformed care system that we're working on moves from the things on the left to the things on the right. I'm not going to read all of them, you can read them yourselves, but one that I think is important, the third one down, episodic treatment. So instead of just, we're just hanging out, waiting for you to get sick, come in. Instead, we want to be more proactive, help you be holistic. Look at all of you, not just your big toe, and help you think about how your lifestyle contributes to your health. So you're going to see all of us shifting more towards a wellness orientation. I think the bottom one on this is particularly important, and this shift is so profound. As a kind of an insider, I just can't tell you what a game changer it is to focus on cost instead of revenue, to create a wall between the actions that we take to benefit the patient and the revenue that we get to do that. It's going to make all the difference in the world. Think of it as all the money comes down in just a big bucket. And if I need a little bit to take care of the community or the doctor needs it to give somebody surgery, we just go to the bucket and we get it. And so we no longer have to worry, not yet, later when this happens, we no longer have to worry about billing per each discrete item. That's the hope anyway, right? So that was the 10%. Now thinking a little bit about the 90%, because this is public health, and this is what a lot of us think about in our day jobs and our avocations. We need to think about the environment, policies, systems, culture, how we partner, how we develop coalitions. These are just some pictures in Northampton that showcase a healthy environment, although I don't think that woman, and I know that dog, is not wearing a helmet.
Nor on the cover of the program today.
Oh, really?
Yes.
Lisa? So first of all, what does an integrated care system look like? Well, so I want to pay attention to prevention because that's what I do. But you do have patients with COPD and they need oxygen, they need medication, they need home care, they need all that. And we do all that for them. But think about it for a minute. They still have a life, they still have a family, they still want to go out to eat in a smoke-free restaurant and enjoy their family. So, pretty good example, right, of how public health and the medical care system can work together, and we really have to do better at that. Again, it's that vision, coordination. And somebody told me to put behavioral health at the bottom, so I listened and I did. And sometimes I take it off and sometimes I put it back on, so today it happens to be on. I think we're seeing more and more that it is such an important thread in everything that's going on here. Mass General they now own us at our request. And I'm not sure why that's funny, but they did an assessment of their inpatients and found that 40% of their inpatients have some sort of a substance abuse related thing going on. Think about that, 40%. And now you add somebody who is older, they have COPD, and I don't know about you, but when I can't breathe, I tend to feel anxious. So these patients who have these conditions, they do feel anxiety, they do feel depressed. And so the behavioral health part is really, really important. And we're finally beginning to talk about that within our own walls, instead of just saying, oh, let's send them up to the 5th floor, or let's move them on out. We're actually having those conversations a lot. And I'll tell you, it's really overdue. Now, if we can only get the payment system to support us to do that, we'll be okay. Just a quick slide that I borrowed from our friends at Cheshire Medical in Keene, New Hampshire. And the idea is to line those arrows up. If you work with the schools to have healthy school lunch, that's lining the arrow up, right? Because if they can't do that, and the child ends up becoming a 30, 40, 50-year-old after a lifetime of bad eating habits and they get diabetes, the arrows aren't lined up. We have a lot of work to do in our country to line those arrows up. It's going to be certainly the rest of my working life and probably many of you. But as you can see with that big yellow circle, when you do line the arrows up, you do get a much bigger benefit. So that's the hope. I hate words on a slide, but I thought this was important to at least give you the definition. And you have it on your handout, so I'm not going to read it to you. Nobody wants me to, right? They're all shaking. I'm going to very briefly just put up determination of need, and then I think Anna Marie is going to get a little bit more into that. But basically the idea here is that if Cooley Dickinson buys 12 CAT scans and Bay State, because they're bigger, buys 37, do we really need that? I mean, we don't, right? Everybody knows that. So the state has a vested interest in making sure we don't do that. So anytime we want to do something like that, we have to go through a process to get approval to do that. And as a little bit of a bonus, DPH requires 5% of the cost of the project to be tithed to community health, usually spread out over 5 years. And that's a negotiation between DPH, the hospital, and the community, sometimes the CHNA if there is one. And they're currently looking at the DOM process, so stay tuned, that will be changing. So I'm jumping around a little bit. We have until 2005. I want to leave Anna Marie as much time as she needs. So why conduct a health assessment? So I think I'm missing a transition slide, but basically the idea here is that in whether it's community benefit, or which we'll talk about later, or determination of need, rather than somebody like me picking the project, or rather than somebody like you picking the project, what we really need to do is find out what the facts are. And that could be looking at data, it could be talking to community members, it could be just some sort of a process of engagement where we find out what are the real needs here, what's going on. And the Massachusetts Attorney General has had voluntary guidelines for the last 20 years. And we have all voluntarily complied because it's been clear if we don't, they won't be voluntary anymore. However, the Affordable Care Act now has the IRS in the game, and they are not even pretending to be voluntary. And that's a really fun time every April, isn't it, Anna Marie? But the other reason to do the health assessment is really strategic. As I said before, if the money's driving us towards a prevention orientation, do your health assessment, find out what's going on. Don't just do it to satisfy the bureaucracy, do it to actually benefit real people. And so that's really the important bullet on the slide, is it has to fit with the strategy. And find out from your local hospital if it isn't one of ours, and push them to think about that. I'm not going to get into data. I only wanted you to know that we do have some. And we have a report. Has nice colors on it. The way we use data, though, in this example, the middle one with the blue at the top is East Hampton. Anybody live in East Hampton? Oh, several of you. Well, I live near East Hampton, and it's a great little community, but it sure does have really high death rates from heart disease and cancer. Anybody want to know what? Anybody want to guess why that is? Smoking. Yeah. So we have an initiative. We're working with them to reduce smoking, and also healthy eating, active living, and it's going to take time. If we prevent a 15-year-old from smoking and they don't get lung cancer when they're 55, I don't think I'll know, but it's still the right thing to do, right? So even though it has a long incubation period, and we know that in public health, doing the right thing is the right thing to do. You've got to do it. It will have a payoff. Certainly financially, although it's a little bit iffy because it's so far down the road, but it certainly has a payoff to that 15-year-old, and I think that's a good enough reason to do it. Real briefly, in terms of community engagement, I really love this slide, and actually the one that follows it even better. We asked people in Northampton, do you garden? And take a look at the bottom three. They don't. If anybody knows Northampton, you know these are the low-income housing communities. Nobody gardens there. But now when you ask, if you don't but you'd like to, now look at the top 3. And this is really a policy decision, right? This is something we could do differently if we chose to have the political will to do that differently. We could give people opportunity to lead healthier lives. And this is really what health equity is all about. It's really looking at the data intelligently, engaging people and collecting the data, and then helping them figure out solutions to their lives. In this case, the solution will be working with city planning, Department of Public Works, maybe getting some state money. And also, maybe thinking when we build these things to begin with, doing them differently. Maybe it's not that smart to put them 2 miles out of town where there's no bus route. Just saying, maybe it isn't. So those are the sorts of conversation. I can put that back if you're taking a picture of it. Okay. All right. So I think Anna Marie's going to talk a little bit about a regional health survey that all the hospitals, or most of us, participated in together. I got to say, that's pretty groundbreaking. And Anna Marie was our ringmaster on that. You know, we do compete. We just beat each other up all the time in lab and primary care and stuff like that. But we also discovered that we can also work together when it comes to community health. And so it was pretty groundbreaking to do the survey. We also did focus groups. We talked to real people. And
Really?
we talked to real people.
Oh, good.
Yeah.
I'm glad to hear that.
Yeah. I'm not saying like I'm not a real person, you know what I mean? But the tie makes me a little bit suspicious, I think. So we paid them to come in. We paid people to come in and tell us their story. As you can imagine, if you have a mental illness and somebody who looks like me is trying to get you to come to a focus group and tell your story, not going to happen. Throw some lunch and some money in there and they'll consider it. And once you get people in the room, they'll talk. Because they have a story, they want to share it. They really do. You got to give them the opportunity. We also did key informant interviews with key leaders just to get a full picture, and then we held forums on 3 topics: East Hampton, mental health, and health access. What was interesting, everybody in all the forums said transportation was an issue. We weren't expecting that, so now we're doing a transportation project, and we learned all sorts of crazy things like. The mother who lives in Sunderland, those of you who aren't from the region, Sunderland is a rural community a little bit north, I think it's north of Amherst. So this mother describes her son with disabilities and she doesn't have transportation. So it's not easy to get him where he needs to go, like at the hospital. So she takes a bus to Amherst to borrow her friend's car, drives to Sunderland, drives to Northampton, drives back to Sunderland, drops her son off, drives back to Amherst and takes the bus back home. Is that crazy? So we think we could do better if we can think a little differently and involve people in the solution at a level that that will work. I'm not going to read the other things. You see what they are. So the way we want to plan, based on evidence, local data, engaging with people, bringing in community partners. Hospitals can't solve these problems, but on the other hand, neither can your agencies. The only way we can do it is if we all pull together and align. Things need to be patient-centered in my lingo, or community-centered for some of you. Obviously cost-effective, measurable outcomes, because my board doesn't want to know if we're actually accomplishing anything. As long as we can say yes, we keep getting money. So you can't discount those last 2 items. What's next for us? We have pilot projects going on. We're going to evaluate them. We'll hear from, I think in November we're hearing about that. Choose more projects. Over time, you'll see us working more and more with community partners, developing a shared vision, working with residents, agencies to improve health, and then working through those big questions: who's involved, who leads, who pays, and lastly, how do we know we improve things? So I think, Anne Marie, come on up, and we will figure out how to change slides.
Before I start, I just wanted to direct you that Cooley Dickinson has a really nice website that lists out all their needs assessment information and their community benefits. So on your sure. That better? Yes. Before I start my presentation, I just wanted to pull up Cooley Dickinson's website. So make sure that you check out their website. You can learn more information about their needs assessment and their community benefit programs. For friends, right, Jeff? So good afternoon. Thank you all for selecting to come and listen to me and Jeff speak today. I'm here to talk a little bit more in depth about community benefits. So what I'm hoping you'll walk away with in the next 10 minutes is an understanding of the definition of what is a community benefit, a little bit more about determination of need, a community health needs assessment, what are the objectives of that, learn a little bit about our process that we just went through, what is an implementation strategy, also called a community health improvement plan, and most importantly, I'd like to leave with some ideas of opportunities that you could potentially partner with us at the hospitals on community benefits, on community health needs assessments, on our implementation strategies. As Jeff said, we can't do it alone, so we are definitely looking for partnership. So what is a community benefit? I have to remind people at Bay State that community benefits are not anything that we do that benefits the community. They are actually, there's actually a definition and it has to meet a criteria. Community benefit is a program or an activity. It has to provide treatment or promote health and wellness. It has to be in response to an identified community need and have a target population. That need needs to be identified through a community health needs assessment, and it needs to be done in collaboration with the community and populations that are being served, and it cannot be provided for marketing purposes. So I also want to direct your attention to this little box down here. On your own time, if you want to learn a little bit more, the key entities that provide oversight for community benefits, as Jeff mentioned, the Internal Revenue Service and the Massachusetts Attorney General. The Massachusetts Attorney General Office have been providing oversight to community benefits in Massachusetts for over 20 years. And you can go to the Massachusetts Attorney General's website at any time, look up any hospital in the state, and look up their past community benefit reports going back 10, 15 years. So you can learn a little bit more about what's actually going on in your community, what your hospitals are reporting. The Internal Revenue Service is more recent through the Accountable Care Act, and so that's, hospitals have now been reporting through the IRS the last 3 years. They're not the same though, which I will explain. So Bay State Health, we have a community benefit mission. It is to reduce health disparities, promote community wellness, and improve access to care for vulnerable populations. This is a framework that we have at Bay State for our community benefits. You will find at a lot of hospitals, community benefits is assigned to one person that maybe is juggling 3 other job responsibilities. Sometimes it's housed in marketing, sometimes it's housed community relations, other times it's housed in other random departments. It's a growing field. It's getting more and more national recognition. There are emerging best practices in terms of what a staffing structure should look like, the number of FTEs, and so believe me, this is something that I'm tracking so that I can continue to put pressure within the hospitals that, you know, we do need more dedicated staff and resources. So right now, our structure is this. We have 2 existing community benefit advisory councils that are very active at Bay State Franklin Medical Center and Bay State Mary Lane. I am still trying to move forward a community benefit advisory council at Bay State Medical Center. And with the change in our hospital leadership, I'm very confident that this will be moved forward much faster than has been previous. So I'm really excited about that. And then my office, myself, and then I have Amy Swisher, who's here. Where's Amy? Is she here? And Michelle Holmgren. They work at Mary Lane and Franklin, and they are my community benefit colleagues, as well as Karen Pullman, who's in the back. And we have a governance committee that's a subcommittee of the board. Jeff, you're a committee at your hospital. You have a subcommittee of your board that also provides oversight to community benefits. And then it goes up to our board of trustees. This is fairly new. We just got the oversight at the board level back in 2010. So this is an emerging best practice as well. This is just a snapshot of what the Massachusetts Attorney General's kind of guiding principles are in terms of community benefits. They want us to have our own mission statement, have support for community benefits at the top of the organization, conduct a needs assessment, and we have to submit annual reports. There's a 30-page document online if you're interested in reading more about it. This is a slide just to talk a little bit about the IRS. So they specifically require that hospitals conduct a needs assessment every 3 years, done in collaboration with the community, has to be made widely available to the public. So you should be able to go on any hospital's website and access very easily their hospital needs assessments. And also board adoption of an implementation strategy, which I'll talk about in a little bit. And if you do not comply, you're at risk for losing your tax-exempt status or getting a fine. This is a quick snapshot of the various community benefit programs at our 3 hospitals. I do have a disclaimer, we do have a 4th hospital now. We recently acquired Bay State Wing. Unfortunately, I have not captured them in this slide, but they also do some really great community work as well. Bay State Medical Center is on the left. Franklin's in the middle and Mary Lane's on the right. You can see the community hospitals are a little bit lean in terms of what we have for community benefits, but that is definitely starting to change. And there's some really great work going on there. And then at Bay State Medical Center, you can see we have a pretty lengthy list. And I have a couple folks here in the room that are representing a few of these programs that I wanted to acknowledge. So we have our Bay State Springfield Educational Partnership, who's in the room, Peter, Marie, Tia, Karen Pullman at Brightwood, she's in the room, and Dr. Lincoln, your grant work we actually count as community benefit as well in the jail, so we have some great representation here. So this is our expenditures for community benefits for the Mass Attorney General and the IRS. If you look at these numbers, they're very, very different. And that's what I wanted to point out to you today. So for the Massachusetts Attorney General, Bay State Medical Center in FY12 gave about $26 million, Franklin 1.7, Mary Lane a little over $1 million. For the IRS, that jumps to almost $83 million for the IRS, over 6.8 for Franklin, and 1.6 for Mary Lane. So what this creates in terms of challenges for folks like me doing community benefit work is explaining this disparity to our Board of Trustees, to our leadership, to the community. Which number do we report and put on our website? Because unfortunately it's not apples to apples. So what the hospitals have been trying to do within the state is advocate with the Attorney General to say, we know you guys have been asking us to do community benefits for a long time, but the IRS now has these requirements. Is there a way that we could kind of marry the two so that it's apples to apples? And they've said no thank you. So that also creates an additional challenge for hospitals because not only do we have limited staff for reporting, but now with 4 hospitals, I have to do 8 separate reports. 4 to the AG, 4 to the IRS, and they all have different programs and numbers, and it gets very confusing. So I wanted to talk a little bit about what goes into these numbers and why there's a difference. So what counts? The orange boxes are really where the differences come into play. So for the IRS, hospitals are allowed to count research dollars, graduate medical education, and Medicaid losses. So for Bay State Medical Center, who's a teaching facility, that's where that jump from 26 million to 84 million, because we have a lot of research dollars, graduate medical education, and our Medicaid losses. And then on the AG side, we're not allowed to count the research and graduate medical education, but we are allowed to count what are called community building activities, which many would argue are economic development type programs, workforce development programs, a lot of the work that a lot of the hospitals want to do to improve the health of and reduce health disparities, but unfortunately the IRS at this time does not allow those to be counted. They both agree that we cannot count unreimbursed Medicare and bad debt. So this is just a little snapshot. So I thought it would also be helpful to talk to you a little bit about how internally our hospital system kind of measures itself in terms of, are we providing enough in community benefit? There are no current legislative or required thresholds. On the federal side, we tend to use kind of a 5% threshold. On the AG side, for a teaching hospital, maybe 3 to 6% of your total patient care related expenses. For a community hospital, 1 to 3%. Then you can also use your tax exempt value as a measure. So this is an exercise that our hospital system has been doing for quite a few years. We were actually one of the first in the state to start doing this. And our finance team did some research and created the methodology. And so this is actually the first time I'm sharing this externally. This is something we typically bring to our board just to kind of give them a sense of where we're measuring, but I thought it would be interesting to share with you. So again, as you can see, the AG, we are under that based on our FY12, and on the IRS, we exceed it. So this is something that I'm trying to educate our leadership on as well. This I like to throw in, some of you may have seen this before, regarding community benefits. We have charity care, bad debt, free parking, public restrooms, and don't forget that free water. So for many years, hospitals were just saying, oh, does this count? Let's throw it in the bucket. Oh, does that count? Let's throw it in the bucket. But now there's, with the AG, with the IRS, we're being forced, and I think it's a great thing, to be more strategic, to be more thoughtful, to base our programs on data, on need, and measure and see what the outcomes are. So we can't just be throwing anything we want into the bucket anymore. Determination of need. Jeff gave a great overview of kind of what the program is and why it's in existence. Bay State Medical Center did a replacement building a few years ago, actually almost 7 years ago now. It was a very significant regional project. It was almost $250 million. And so we had to give about $9.6 million back into community health initiatives. And then we subsequently built out a new emergency department, and we had to do another $2 million. So the 9.6 was very Springfield-centric. We provided funding for the Mason Square Health Task Force, North End Housing Initiative. I'll show you some of those examples on the next slide. And then the $2 million that we most recently did, we decided to share that. And so we gave some money up to Bay State Franklin Medical Center and out to Bay State Mary Lane Hospital. So their community benefit advisory councils have been very active in doing an RFP process to provide mini grants to the community in their communities with those DON dollars. And that's been very exciting. And I think Franklin Medical Center now has their own DON that they're going through, so they'll get some additional dollars as well. And DPH is definitely much more specific now in how they want hospitals to work with the community to distribute those dollars. So at Bay State Medical Center, as we gear up to do, if we gear up to do additional DON, we will potentially be looking for partners to help us determine how to best release that funding. So this slide just captures a few of the programs that we funded through our determination of need. Okay, I'm going to go through. Community health needs assessment. We did a needs assessment as a coalition. I'm going to go through these really fast, I'm sorry. It basically came because we were having trouble internally getting the support and the buy-in to really allocate resources to do this legitimately. And so we said, okay, other hospitals might be struggling in the same way. So we went out and talked with them, and they all said yes, and we came together and developed a really great friendship and partnership. And as you can see in the bottom left, Noble and Berkshire did not participate, but if anybody's in the room, we'd love to have you join our coalition. So for our needs assessment, we did secondary data analysis, we did primary data with key informant interviews, a community survey that Jeff mentioned that had over 3,500 regional responses, that was done online in hard paper copy. And then our consultants did a priority setting process to determine the top needs for each of our regions. So these were the different indicators that were looked at. This is how our 3 hospitals defined their service areas. Implementation strategy is really taking the needs assessment to the next step. So now you've identified these needs. The IRS now wants the hospitals to say, okay, how are you now going to address some of these needs? And so they asked the hospitals to go through a priority setting process because we can't address all of the needs with our limited resources. So each of the community benefit advisory councils at Bay State and then we had a task force at BMC that came together and we did an exciting implementation strategy priority setting process. So basically we were looking at the needs, we were looking at our existing programs, seeing where there was alignment and where there was potential opportunity to establish new programs. The reason why we have to priority set is because we can't address all the needs. We want to ensure that we have the most strategic investment of our limited resources. And it's also a requirement to do so. So this is a snapshot of Bay State Medical Center's needs that came out of our needs assessment. The yellow ones are the ones that were identified as the top four priorities through our implementation strategy. So I'll just read them off real quick. Need for care coordination and culturally sensitive care, prevalent infant health, maternal child health, lack of access to mental health services and poor mental health status, and high rates of diet and exercise-related diseases and mortality. This is for Franklin Medical Center. They had care coordination, high rates of alcohol, tobacco, and drug, and mental health. And Mary Lane had alcohol, tobacco, and drugs, mental health, and high rates of diet and exercise. So there's some overlap. So our coalition is continuing to meet. We're convening monthly. We've identified a regional shared health priority with behavioral health. So H&E has provided us some seed funding, and we're going to hopefully go after some additional grant dollars, but we're going to be looking to the community to help us with this and really dig deep and understand what is working in our region around behavioral health, what's not, and how can the hospitals partner with people in the community that are already doing great work. So we're putting out an RFP soon to identify a fiscal agent and to have a planning consultant help us drive this work forward. And we're also exploring what our collaboration is going to look like for future community health needs assessments. So there's some opportunities that I wanted to present to you in terms of how you can get involved to learn more about the work your hospitals are doing. Most of your hospitals have some form of community benefit advisory council. And then following the needs assessments, there'll be the implementation strategies, and we need community input into those as well. We're gearing up, planning for our next needs assessment, and we definitely want to get more community involvement. And we're also looking to, I know at Bay State, we want to establish more metrics for our programs and to see if we're actually, improving the health of our communities. So that was a quick snapshot. I do not have copies of my presentation, but I am happy to share it with you by email, and I have my card up here as well.